The third Caribbean Antimicrobial Stewardship Conference is brought to you by Biomerieux, Beckman Coulter, Radiometer, and Pharmapex.
Curacao has a hot new vibe and is now the place to be. An explosion of art, architecture, and restaurants has spurred redevelopment, transforming Curacao into one of the hippest destinations in the Caribbean. But the island still radiates its European charm, natural beauty, and wonderful mix of Dutch, Spanish, Caribbean, and African cultures. Visitors must go and feel it for themselves. Located on the outer fringes of the hurricane belt, Curacao is easy to reach by nonstop flights from 6 North American gateways and by same-day service from 40 cities in the USA and Canada. Still a member of the Kingdom of the Netherlands, daily nonstop flights arrive from Amsterdam, and many flights arrive from South American and Caribbean locations. English is spoken widely, along with Dutch, Spanish, and Papiamentu, the local language. Curaçao's dry, sunny climate and an average temperature of 87 degrees Fahrenheit make it a mecca for every variety of outdoor activities. Visitors won't have to change money. While the official currency is the Netherlands Antillean Guilder, or NAF, US dollars are widely accepted. And the water is safe to drink, straight from a modern desalination plant. Want to know more? Watch our other videos to learn all the things you need to know for planning personalized dream vacations. You'll see where to stay, lounge, dine, and party. You'll get tips on the hottest areas like the Peter Mai district, the best beaches, where to access shore and ocean dives, and all kinds of land and water-based activities, some that are unique to Curacao. So, welcome to Curacao and its hot new vibe. Visitors must go and feel it for themselves.
Bom dia, meu nome é Indiomar Angélica, eu estou trabalhando na ADC Curaçao, o laboratório mais especializado no Curaçao. Ele consiste de 6 departamentos, então a mim analista no departamento de medicina e microbiologia. Na 2008, a ADC cumpre sua primeira FITEC, primeiro que se estava usando o qual que nós chamamos API-strips. Então, é gevoeligheid dat wordt assim manual. Dus, primeiro, dat op je tempo dat bij perder. Então, depois que o vai ter que vir para começar a fazer uso de tempo para outra coisa. Eigenlijk ADC compra Vitec voor de biomerieus Pharmapex. Então, estava sempre betrouwbaar. Então, nunca não havia nenhuma outra opção. Dus sempre aqui na Vitec. E Vitec aqui tem sistema de verdun automatizado. Então, você switch fácil também voor de richtlijnen de CLSI com o CASP. E Vitec também de biomerieux, então biomerieux é uma companhia reconhecida para hopi Anhacaba, então esse está assim é Vitec hopi confiável.
My name is Rudy LeBlanc. I am a clinical chemist and I am the CEO also for Laboratorio de Médicos, LabDeMed, in Curaçao, who has been servicing the Curaçao community for over 40 years now. Before the film array, we couldn't answer questions that physicians sometimes have when they do their differential diagnosis. And that was something that was bothering LabDeMed for the longest while, because we want to remain relevant for our community. So when we researched and found out that we could use the film array to help doctors do a better differential diagnosis, we immediately went for it. Because, for example, most of the microorganisms causing flu-like symptoms they are distinct. However, the symptoms could be the same. So nowadays we can help physicians diagnose more directly and in a more efficient way, because the film array also allows us in a very short time to give a result on, I think it's more than 16 microorganisms that might be able to cause flu-like symptoms. Well, the film array is the test panel, the options that we had in the test panel that gave us the opportunity, or actually, yes, that gives us the opportunity to report out to the physician a larger panel that they can actually diagnose a lot faster, a lot more efficient. Oh, absolutely not, because we were actually looking for a good solution, like to answer the questions that our physicians had. And we wanted to be and wants to be relevant to our community. A rapid diagnosis, client satisfaction, patient satisfaction, and quick response turnaround time, and quick relief of symptoms and patient problems.
The purpose of this video is to show the process for collecting blood culture specimens and inoculating BACT-alert blood culture bottles using the syringe draw method. At the end of this video, you should be able to collect and inoculate blood culture bottles using the syringe draw procedure. Required materials: BACT-alert bottles. All bottles will have fill level markings. Certain bottles will have a fill to mark. Chlorhexidine gluconate prep, or equivalent to clean the venipuncture site. Tourniquet. Alcohol prep pads. Syringe and safety needle. Gloves. Transfer device. Sterile gauze. Band-aid or bandage and tape. Specimen transport bag. And marker if required based on bottle type. Have all of the necessary supplies within easy reach. Identify the patient according to your facility's policy. Select the venipuncture site. Clean the selected venipuncture site as recommended by your facility's approved procedure. Do not repalpate the vein. Allow to air dry. Inspect the BACT-alert bottles for cracks or contamination. The sensor should be a blue-green color. If yellow, do not use. Check the expiration date on the bottle. If expired, do not use. Unless the bottle has a fill to mark, mark the maximum fill volumes from the fluid line. Adult is 10 milliliters, pediatric 4 milliliters, using the pre-marked increments on the bottles. Remove the plastic flip top and clean the septum with 70% alcohol or equivalent. Allow to air dry. The plastic flip top is to protect the septum only and does not make the septum sterile. Assemble the syringe and safety needle device. Perform the venipuncture and aspirate 10 milliliters for each adult bottle and 4 milliliters for the pediatric bottle. Aspirate additional blood if other testing is required. When the amount of blood required for all testing has been aspirated, remove the tourniquet. Terminate the venipuncture by placing a piece of gauze over the puncture site and withdrawing the needle from the vein. Activate the safety device and detach the needle from the syringe. Discard the needle into a sharps container. Attach the safety transfer device to the syringe. Inoculate the anaerobic bottle first, and then the aerobic bottle. Blood flow will not stop at 10 milliliters, 4 milliliters for pediatric. Keep an eye on the level to prevent overfilling or underfilling a bottle. If vacuum tubes are to be filled, insert the adapter insert if required, and fill the tubes in recommended order of draw. When inserting the adapter, hold by the outer lip. Do not place fingers in the hole to prevent finger stick with the needle. When the final tube is filled, discard the transfer device and syringe into a sharps container. Remember, the whole adapter cap, insert, and syringe goes into the sharps container. Invert back T-alert bottles 3 to 5 times. Label the bottles according to your facility's policy. Avoid placing labels completely over the bottle barcode or on the bottle sensor. Bandage the patient when bleeding has stopped. Place bottles and tubes into a biohazard bag and transport to the lab as soon as possible and according to your facility's policy. In summary, to collect blood cultures using the syringe draw method, have all the necessary supplies within easy reach. Identify the patient. Select and clean the venipuncture site. Inspect bottles. Mark the fill volumes and remove the flip top and clean the septum. Assemble the syringe and safety needle device. Perform the venipuncture. Aspirate the appropriate amount of blood. Place a gauze over the puncture site and withdraw the needle from the vein. Activate the safety device. Remove the needle from the syringe and discard it into a sharps container. Attach the safety transfer device to the syringe. Inoculate the anaerobic bottle first, then the aerobic, and finally any additional tubes if required. Discard the transfer device and syringe into a sharps container. Invert the bottles 3 to 5 times. Label with patient information. Bandage patient arm. Place bottles and tubes into a biohazard bag and transport to the lab.
Hi, Momini. My name is Javier Manumbaro. I'm a lab technician at ADC laboratory in Curacao. The laboratory consists of 6 departments, and I'm currently working in the Department of Microbiology. Way back, before we had the bug alert, we had incubators, 36 degrees incubators, and we stored blood culture bottles in those incubators, and those bottles were analyzed every amount of days to see if it's positive or not. Actually, we didn't have other options. The bug alert was our first instrument for blood cultures. The features of this instrument that caught our eyes was the way it performs. It is really easy to use, and it's also really easy to learn. By achieving this instrument, more reliable results, the workflow is also better. bioMérieux is the biggest company for distributing the blood culture instrument, and by gaining this instrument, it's a big achievement for our laboratory. It helps the workflow. It also helps. It's also easy to use. It also easy to learn, and hands-on time is also less.
This video explains how to use the Acquisition Station software to run a Vitek MSDS target slide on the Vitek MS instrument. At the end of this video, you should be able to run a target slide on the Vitek MS instrument using the Acquisition Station software. Required materials: a Vitek MS Acquisition Station computer and software, a monitor, a keyboard and mouse, a barcode scanner, Vitek MS instrument, and a prepared Vitek MSDS target slide. Note: slides should be tested within 48 hours of sample preparation. The Vitek MS Acquisition Station software is used to monitor and display the instrument status, perform sample analysis activities, and can display previously acquired spectra. This video will focus on sample analysis activities and the steps used to acquire spectra from a Vitek MSDS target slide. If necessary, log into Windows on the PC by pressing Ctrl-Alt-Delete on the keyboard. Enter a Windows username and password. Note: if you have a Vitek MS Plus, double-click the switcher icon on the desktop and verify the system is in IVD mode. On the Windows desktop, double-click the Vitek MS Acquisition Station icon to launch the software. Log into the Acquisition Station software by entering a Milo username and password with Vitek MS Tech privileges. The acquisition screen displays by default. The screen is divided into several sections: the title bar, the navigation bar, the progress display, the camera viewer, the spectrum display, the action buttons, the information display, and the logout button. Verify all Vitek MS target slides to be tested are completely dry. Wearing powder-free gloves, click the Open button on the right side of the screen. The sound of valves pulsing and hissing can be heard as pressure is released from the system. The pressure must reach approximately +3 millibars before the door will open. This takes just a few minutes and can be monitored on the lower part of the screen as the source pressure bar changes from green to orange. When the Vitek MS instrument door opens, remove the adapter from the carrier. If present, remove any previously tested slides and store or discard according to your laboratory procedures. Place the target slides into the adapter in order, beginning with position 1. The proper orientation of the slides in the adapter is as follows. The top of the adapter has the angled corners. Slide position 1 is closest to the angled corners. The target slide barcodes are positioned on the left side of the adapter. When all the slides are loaded, scan or enter the target slide barcodes in order beginning with position 1. As the slides are scanned, the software displays a slide graphic of the sample spot positions. Verify the correct barcode displays. If a barcode is not recognized, make sure the slide information was sent from the prep station. Send slide button. If an incorrect barcode is entered, click the Erase button and re-enter all barcodes starting with the slide in position 1. No acquisitions can begin until all slide barcodes are entered correctly. Load the slides into the instrument within 5 minutes of the door opening, since the door closes automatically after 5 minutes. Gently slide the adapter into the carrier until you meet some resistance and it will go no further. As you slide your fingers across the back edge of the adapter, it should feel slightly concave. Note: the adapter can be put in backwards but will feel more convex. Testing will fail if the adapter is loaded incorrectly. At the acquisition station, click the Start button. The adapter retracts and the vacuum system starts. The instrument should reach an operating pressure of approximately -6 millibars within 5 to 10 minutes of the door closing. The vacuum level can be monitored on the lower part of the screen as the source pressure bar changes from orange to green. If it takes more than 10 minutes to reach the operating pressure, the desiccant may need to be changed. The acquisition begins by testing the calibrator spot of the first acquisition group. If the calibrator passes, the patient samples in the acquisition group are tested. If a calibrator fails, no samples are tested in that acquisition group, and the instrument moves to the calibrator spot of the next acquisition group. When all samples in the group are tested, the calibrator is read one more time as an internal quality check. Results are sent to Milo when testing of an entire acquisition group is complete. During testing, the acquisition station target slide graphic displays various colors for each spot to indicate the status of each sample. Samples that fail can be reacquired at the end of the run by clicking on the spots and selecting Start. When the acquisition is complete, select the Open button and remove the target slides from the instrument. Slides that are completely used should be discarded according to your laboratory procedures. Slides with available acquisition groups can be stored at room temperature, protected from dust and aerosols, to be used at a later date. Summary: log into Windows on the PC. Log into the acquisition station software. Click the Open button. Place the target slides in the adapter. Scan the target slide barcodes. Load the adapter with the slides into the instrument. Click the Start button. When testing is complete, click the Open button and store or discard the slides according to your laboratory procedures.
Well, it was like the Flintstones area. And nowadays we are in the modern age. We actually did a lot of stuff manually, and which worked well for a time period. However, as soon as your samples increase, but also requirements, international requirements, but also requirements by physicians become much more sophisticated. You need more sophisticated equipment and technology procedures in order to meet the needs of your community, of the medical community nowadays. Okay, with the VITEC, considering we did a lot of testing manually, for example, nowadays physicians use a lot of times the MICs in order to determine what kind of antibiotics and how much antibiotics they have to give. So we identify that as a lack that our lab was having, because we were measuring the distance from the middle of or actually the distance around the discs, the antibiotic discs, and which is good, but it's not as accurate if you're using the MICs. So that's the reason why, one of the main reasons why we started doing microbiology with the VITEC. One of the major things, because nowadays most equipment, it doesn't matter that much which company you make or you choose. However, the companies that give backup and support are those companies that stand out. And I can say from the perspective of support, of technical support also, Farm Impact stands out as being one of the companies that you can rely on, and also gives expert advice as to how to implement, and they also provide training, and also they provide that backup that we currently need. I'm not sure if there has been any obstacle, because from the get-go we did our research, and the VITEC stood out as being the equipment that we made a choice for. And like I said previously, it is the backup, it is the feedback that we got from the company, and also the support that we got from the company BioMilieu, and also Farm Impacts, that actually was that tipping point that made us made a choice for the VITEC. Specifically the MICs is something that we were looking for to address with our microbiology service that we are offering. Biomilieu is a very reputable company with many years of experience in the field of microbiology, but also immunochemistry, and it's a company that we have been known, that has been known to us for the longest while, very trustworthy. Like, for example, we had the Mini Vidas, that is a very sturdy equipment, and therefore the reputation of Biomilieu was the thing that we went for, and we also think that the representation of Biomilieu on the island is also very respectable and also trustworthy. I have known Farm Impact since the 90s, and Farm Impact has proven to be a company that is reliable and that can offer the best possible solutions for laboratory issues and problems that we have been facing trying to give laboratory service on the island. And I have to say, the expertise and also the support has been one of the most valuable assets that typifies Farm Impacts. What exceeded my expectations? That Farm Impacts always is willing to go the extra mile, and also even when there are no roads, to find ways to make new roads. And that is one of the things that we found out we found that Farm Impacts is really flexible and trying to help finding solutions. I would tell somebody considering Farm Impacts that is a great company, that you are able to get the best possible solution, and that they are willing to work with you to get to solving problems that you might face. So that is one of the aspects that typifies Farm Impacts, that they are really willing to support you, and it's not, and they are genuine. That is one of the things that I like about Farm Impacts. They are really genuine.
Good morning, everyone, and welcome to the third annual Caribbean Antimicrobial Stewardship Conference in 2020. Remember that this event is hosted by LabKnowledge Foundation. My name is Germán Esparza, and I'm Clinical Microbiology Professor, and I am broadcasting from the beautiful Colombia. I have been lucky to participate in these meetings, bringing updated scientific information related with antimicrobial resistance and proper antimicrobial use and infection control to the Caribbean islands. We all know that these are challenging and difficult times for all of us in every single country. And we all know that we should protect ourselves. However, social distancing doesn't mean academic isolation. And as storms, pandemics don't last forever. We need to keep updating and preparing ourselves for the post-pandemic, where I'm sure that multi-drug resistant pathogens will strike hard again. So with this in mind, we are doing our best to reconnect with all of you until we can get close and hug each other again in a live personal meeting in those beautiful islands. This Caribbean Antimicrobial Stewardship is an effort of LabKnowledge with the support of main sponsors like Farm Impacts and Biomilieu, and sponsors of the day like Radiometer and Beckman Coulter. We are going to present the first webinar session of a mini-series with the topic of sepsis, what is really current and probably the most dangerous threat for patient care nowadays. We are going to hear a couple of presentations today from two experts in the field who will share with us their knowledge and personal experiences with sepsis and fungal infections. Remember, guys, that you can type your questions in the chat room or you can request to speak, which appears in the right side of your screen. Keep in mind that we have more than 100 participants, so we can accept all the requests. However, you can type your questions in the chat room, as I said. For the polls, please press the poll button and select the option you consider is correct. Remember also that to obtain your certificate of participation, you must fill in the questionnaire at the end of the webinar. It will appear at the end of the screen, so please make sure you stay till the end. Every institution who have registered will later receive a package at their lab with incentives from LabKnowledge, sponsored by bioMérieux. And now, it's my pleasure to present Mrs. Neila Diaz, who is going to give us an introduction to LabKnowledge. Please welcome Mrs. Diaz.
Good morning, good afternoon, or good evening, depending on where you're joining us from. Welcome to the third edition of the Caribbean Antimicrobial Stewardship Conference. We are so glad to have so many of you joining us from your offices, your labs, your hospitals, and whether you are connected by yourself or if you are following this seminar with other colleagues, thank you for investing this time in the fight against infectious disease. I want to thank the wonderful team of people who have worked and continue to work tirelessly behind the scenes to put this conference together in this new format. A special and heartfelt thank you goes out to all our speakers for their willingness to take the time to share and interact with us today on various topics. A sincere thank you goes out to our sponsors, for it is in this collaboration between industry and the front lines that we are able to leverage resources towards common goals. Lastly, thank you for being an engaged and active participant today. The Caribbean Antimicrobial Stewardship Conference is hosted by LabKnowledge and is made possible by contributions from various sponsors. LabKnowledge is an institute for continuing education and research in laboratory science and is fully funded by Pharminpex. 4 years ago, in a year-end debriefing following our travels throughout the Caribbean, I shared with my team the observation that there are a lot of good efforts going on in the Caribbean, specifically in the area of infectious diseases, antimicrobial stewardship, and infection prevention and control. But that unfortunately, there were not many avenues for this information to be exchanged among the countries and institutions of the Caribbean, and most importantly, between lab techs and medical practitioners themselves. I also noticed a real interest from all organizations to engage in continuing education and a commitment to fight infectious disease despite the lack of resources. These observations gave rise to the establishment of the Caribbean Antimicrobial Stewardship Platform, a LabKnowledge initiative in which the focus was to create an avenue for sharing knowledge, practical experiences, and best practices, promote collaboration between islands, organizations, and individuals in the fight against infectious disease, and provide the infrastructure to link not only global, but especially our local Caribbean experts and make continuing education initiatives more accessible. In 2017, thanks to a funding guarantee by Pharminpex, LabKnowledge committed to a 5-year cycle to host the Caribbean Antimicrobial Stewardship Conference. The first conference was held in Curacao in September of 2018 in collaboration with NASCO, the Dutch Caribbean Foundation for Higher Clinical Education. In October of 2019, the conference was held in Barbados in collaboration with Dr. Corey Ford and his team from Caribbean Infection Prevention and Control. This year, the conference goes online and is spread over 3 consecutive monthly live webinars covering the topics of sepsis, infection prevention and control, and antimicrobial stewardship. Last year in Barbados, I was very much inspired by the breadth of medical professionals from all areas of healthcare who felt the importance to engage in infection prevention and control. It led me to declare in my opening statement that together we can create a world in which there are no more deaths from infectious disease. While this may seem like a bold statement, and while it may be true that the results may not come overnight, this vision of our future is still worthwhile. In a year where we face the challenges of coronavirus, it may be easy to feel overwhelmed or feel like this problem is too big to solve. Still, there is a lot to celebrate. I want to remind each and every one of you that you are an important piece of the puzzle. As a healthcare practitioner, your choices directly impact the lives of people in your community. Most of these people don't know you, or most of these people may not comprehend the role you played in their health and well-being. You may not receive the recognition you feel you deserve. Despite all this, choose to make a positive impact and choose to make a difference in the fight against infectious disease. We may or may not be the generation that will eradicate death from infectious disease, but if we all do what is within our reach to contribute, we will be the generation who made significant progress on this issue so the next generation can get a head start. And that is certainly worth celebrating. Enjoy the conference, and above all, share, interact, learn, and commit to the action that is within your reach to create a world in which there are no more deaths by infectious disease. Thank you.
Thank you very much, Mrs. Diaz. I agree. This is going to be a fantastic. And now it's my pleasure to present Dr. Radjin Steingrover. He's an MD specialized in clinical microbiology and has spent the last 4 years working to improve clinical microbiology in Curaçao and St. Maarten, to report on regional trends and antibiotic resistance, to coordinate antimicrobial stewardship efforts, and to lead hospital hygiene departments. He has a background in clinical microbiology and international HIV research. He's also head of the Department of Clinical Microbiology at St. Maarten Laboratory Services and leads the department and hospital hygiene in the St. Maarten Medical Center. He has published papers in peer-reviewed journals and serves as an editorial member of a Dutch journal on infectious diseases. Dr. Steingrover is going to speak us about clinical microbiology of sepsis in Caribbean islands. So please give a warm welcome to Dr. Steingrover.
Thank you very much for that introduction. I hope you can hear me properly, and let's see if we can start up the slides. I think you have the first slide in view. Let me see. All right. Thank you very much for the introduction again. It is an honor, and I'm excited to be the first speaker on this wonderful webinar jam platform that indeed takes us out of isolation in a time where we can't travel, and have a wonderful continuation of the Caribbean Antimicrobial Stewardship platform. So I'm very appreciative of the effort to do this online. What I have prepared for you is a discussion on sepsis, as we are in Sepsis Awareness Month and only a couple of days past World Sepsis Day. And sepsis is, in my opinion, the sort of crossroads where urgency and antimicrobial stewardship meet in a sort epitome of importance. And I think, although we are all probably overshadowed by COVID-19 this year, as soon as we have time for other stuff, the bacterial sepsis, perhaps even the gram-negative sepsis, will come back in its importance as it used to be. What I'm going to do is start us off with some familiar territory. I'm sure you have seen many of the slides that are very familiar to us working in sepsis. If you look from a mechanistic view, sepsis, starting with the lipopolysaccharide superantigen and toll-like receptor with intracellular cascade for effect. I'm sure you are familiar with those kind of concepts. But I want to take you on a more clinical track, and that's where survival comes into play. And we want our patients to be treated optimally, cure from sepsis and survive sepsis. I'm not sure if you are familiar with this slide, but this graph by Angus and Wax shows you survival over time for patients with sepsis, taking us back from the 50s on the bars on the left side, all the way up to 2006 bars on the right side. And you can see mortality decreases over time from over 60, close to 80% in those early bars, moving down to 40 to 30% in those later bars. So are we doing it better over time? Is our healthcare capable of improving sepsis survival? If you look at the Angus and Wax paper, it was published in 2001, so that gives you, this is not the original slide. If you look at that original slide, however, you see that over time the numbers surveyed in this review increased dramatically. So you can't really say sepsis improves. There may be other effects in terms of surveillance, and that surveillance effect is a continuing trend up to this date as sepsis criteria change over time. So you see increased surveillance of sepsis, and you see perhaps a more accurate number in those later years, bringing mortality to 40% or approximately that figure. I mentioned the sepsis criteria, they keep changing. We are now in an area where we are supposed to have sepsis criteria defined by the SOFA score, the sequential organ failure assessment. And if you have a SOFA score change of 2, then you meet sepsis criteria. When you remember way back surviving sepsis campaign starting out, we were used to have a more clinical approach. SIRS plus infection used to be the definition, and maybe you remember going around, well, temperatures over 38 or leukocytes over 12 were meeting sepsis criteria and were the starting point to escalate therapy. We have advanced from that. We have added biomarkers. I'm sure one of the presenters will talk nicely about biomarkers in sepsis. We are measuring CRP, perhaps procalcitonins. But at this time, sepsis 3 criteria are based on the SOFA score. Just for illustration, I'm not going to walk you through it. SOFA score will show you vital parameters like blood pressure, saturation, mental status. And if you have a change or impairment, then you will meet sepsis criteria, indicating the organ failure component of current sepsis definition. Still painting the picture of sepsis as we know it, some great studies in the past. This is 2001 Rivers, showing you results of early goal-directed therapy in the treatment of severe sepsis and septic shock. A hallmark study introducing the early goal-directed therapy strategy for sepsis. What they did, I'll show you on the next slide, is have a randomized trial intervening in severe sepsis and septic shock patients to have them as early as possible improve on vital parameters like respiratory parameters, hemodynamics, saturation. In those first hours, these were monitored continuously and treated proactively to meet their predefined goals. The standard care group had less of these parameters and less active intervention. Well, did that work? If you work so hard on these patients, does it improve survival? Indeed, it did. Otherwise, it probably wouldn't have made to New England. Here, intervention group mortality 30.5% versus 46.5% in the non-intervention group, standard care. Highly significant. And indeed, if you have a mortality change this big, it is quite a relevant find. One of the hallmark studies, early goal-directed therapy, and I'm sure you will recognize some elements or maybe all in the care in your hospital, in your treatment protocols. This is one of the most famous slides in sepsis areas. This shows you the study of Kumar and colleagues in critical care 2006. If you look at the graph, it shows a function of time to effective antimicrobial initiation versus the onset, taken from the onset of hypotension, another hemodynamic criterion. And if you look at the graph, it's almost a perfect function. The later you start effective antimicrobial therapy after the onset of hypotension, mortality increases. So this puts us to task to start effective antimicrobial therapy as soon as possible, affecting the survival of our patients. We've seen many interventions being tested and studied and trialed. Not all of them were effective. In fact, hydrocortisone, granulocyte stimulating factor, and activated protein C, none of them showed any effect when tested in a randomized clinical setting. One of the editorials showed another failed intervention for septic shock because they lack efficacy when tested in a trial setting. Great studies learning us, but not providing such dramatic improvement in survival as the other studies. The same author, Kumar, again in 2009 in chest. Somehow he has a nose for dramatic effect. Here, studying the initiation of inappropriate antimicrobial therapy. If inappropriate antimicrobial therapy is initiated, survival is reduced a 5-fold. Reversed, appropriate therapy improves survival, putting us to task again to initiate that effective therapy as soon as possible in our patients. This is a retrospective review of over 5,500 patients. In 20% of these patients, therapy was inappropriately classified by the reviewers, and the difference in survival was a 5-fold. The actual figures: inappropriate antimicrobial therapy, survival was only 10%. Appropriate therapy, survival was 52%. Quite a dramatic difference there. Knowledge from these studies, they are represented to us in guidelines. Management of sepsis, this is Rhodes 2017, intensive care medicine. One of the nice things of this paper is that it has a table comparing the 2012 recommendations and the 2016 recommendations on the right. You can see that the recommendations for 2016 are overall more extensive. There's more to do, more detail there. And I think it's too small for you to read, but lower you see diagnosis. If you look at how you establish diagnosis, they basically say, well, do routine cultures, as long as you don't delay initiation of antimicrobial therapy. And that is very meager, that's very minimal. Routine diagnostic cultures, yes, for sure. It must include blood culture. But in contrary to the general recommendations, the recommendations for the diagnosis is very limited, just routine cultures. 2020 SOFA scores. This is a picture of one of the tools represented from the Surviving Sepsis campaign, a pocket card. It shows you how to spot adult sepsis. If you look at the SOFA criteria of saturation, bilirubin, platelet counts, the requirement of vasopressors, serum creatinine output, urine output, and on the right you see treat sepsis as an emergency, act within that 1 hour, initiate vasopressor, source intervention, and fluid resuscitation. Indeed, treat it like an emergency, putting us to task. To summarize, use SOFA score, act fast, early goal-directed therapy, and prescribe appropriate antimicrobial therapy. Now, that last thing is very important, obviously, but how do we do that? One of the things is that we take routine cultures, but you may add in these times rapid diagnostics. And there are several to choose from. You can use biomarkers, you can use antigen tests, you can use PCR panels. And in presentation last year, I showed you the effect that we had in the St. Maarten Medical Center with BioFire respiratory panels in the pediatric department. If we just focus on that graph, the most important graph there, it gave us information in the pediatric department for community-acquired respiratory sepsis, if it were bacterial or viral pathogens. And that's one, in at least in pediatric infection, a very important distinction. And it gave us the actual information. The other thing, if you want to prescribe appropriate antimicrobial therapy, is you have to know your local resistance figures. We worked in Curacao to establish those for a couple of years. And if you do that structurally, you'll find you can identify trends in your antimicrobial resistance, but you can find data how you prescribe effective empirical therapies. So here you see Klebsiella pneumonia from blood cultures. You can see there cefotaxime on the right, indicative of your prevalence of ESBLs. And you see that ESBL is significantly in Klebsiella over 20%. You can see meropenem on the right. It's quite effective, obviously, for indicating a very low prevalence of carbapenemases in this Curacao population. For the gram-positives, another very important marker to find is how much MRSA do you have? Can you treat empirically with flucloxacillin and penicillins or cephalosporins, or do you need to add vancomycin? And here you can see flucloxacillin in blood cultures in Curacao. A significant amount of MRSA is there, a couple of percent all over the years. And you may want to consider to use vancomycin if in doubt of MRSA infection. Then there's something else. You have to establish procedures to assume the right kind of focus in your infection. Differential diagnostics, but with a focus on the infection. You have to find the anatomical location, and you have to make assumption on the pathogens that you will find and treat. In one of the books on sepsis that I happen to own, is this described as a best guess. And I'm quite surprised by that label. Appropriate antibiotic is a best guess what to be used based on clinical suspicion of the site of infection and the likely organisms. I want to take you through some cases to see if we can do something better than just a best guess, although it may be just that. Before we enter cases, I'm gonna bother you with one poll to see if we can learn from each other. The first question is taking us back to sepsis criteria. Starting a poll right now, asking you, what kind of sepsis criteria do you use? You can choose if you use still classical features like temperature, blood pressure. Do you actually use that SOFA score? Do you use something else? Perhaps you're not using any, or if you're not sure, you can choose, I don't know, to see what's going on. I see figures coming in, both for classic and SOFA scores. We'll just let that poll run, and we'll have a look at the first case while we get back to the poll later. Case 1 is a 50-year-old male presenting to the hospital. He has a recent history of gallstones and a recent cholecystitis event. He's on a waiting list for cholecystectomy. He has a 2-day history of right upper quadrant abdominal pain, tachycardia, pyrexia, and he has been treated with amoxicillin, clavulanic acid, and paracetamol by his GP, but apparently little effect. So the GP refers to the ER, where they find a systolic blood pressure of 70, heart rate of 145, and a temperature of 40 degrees Celsius. Well, that clearly points to a certain direction. So if we can make a best guess, our differential would definitely include the biliary tract as one of the focus. Before we continue, let's just end the poll so you can see the results. I see results indicating a lot of the classic criteria based on temperature, leukocytes, blood pressure, but also a significant part having the SOFA or the quick SOFA score in there as well, and only a few who use something else or are not sure. Thank you for those answers. Interesting, because I do think that the classical signs and symptoms, they do give us a pointer in the right direction. Back to our case. At presentation, the airway is patent, breathing has a respiratory rate of 35, there's tachycardia and hypotension, there's warm peripherals, and there's an obvious tenderness in the right upper quadrant. The house officer calls regarding antibiotic therapy, and you must know that in this particular hospital, the ESBL rating clinical isolates is approximately 30%, and carbapenem-resistant Enterobacteriaceae is under 1%. What is appropriate antimicrobial therapy for this patient? Or what would you prescribe? I'm going to start another poll for you. You can enter your option of preference. I'm not sure. Am I back?
Yes, sir, you are with us.
I'm sorry for that interruption. I'm not sure what caused it. Thank you very much for bringing me back. In the poll, we see now options clavulanic intravenously, zero choose for that. May have to do with the treatment with amoxicillin clavulanate by the GP. Cefuroxime, gentamicin, not very popular, 0. There's 50% choosing ceftriaxone, or even extensive therapy, ceftriaxone with an aminoglycoside, gentamicin, or the amoxicillin plus gentamicin. And some would even choose meropenem, carbapenem. As I said, maybe there's no perfect option, maybe there's no wrong option either. I think it shows a selection of effective gram-negative therapy that you expect to be causative agent in that biliary tract. So what happened? Next slide. On the right side, the continuation. Diagnosis of cholecystitis, starting on IV fluid, started on amoxicillin clavulanic acid. But this time intravenously, far higher doses than you can give oral, and sometimes that may work. Apparently the patient was not that sick, but improved quite dramatically after fluid resuscitation, and augmentin fever remained 38 on the next day, but patient was free of symptoms on day 3. So that went well. I do think it is, if somebody is pre-treated with amoxicillin clavulanate, it is not very wise to continue amoxicillin clavulanate if the patient is critically ill. Then you need to be sure that you have effect, and amoxicillin clavulanate may not be the first choice. Case 2. 8-week-old neonate GP refers to the ER. On presentation, the child is lethargic. The systolic blood pressure could not be established. The heart rate is close to 200 beats per minute. Respiratory rate over 60 per minute. Temperature of 40 degrees Celsius. That is high. Diagnosis is sepsis without focus. Pediatrician start IV fluid and cefuroxime plus gentamicin. Perform blood culture and labs. How does it continue? On the right side again. Day 2. Blood culture is positive with gram-negative rods. There's leukopenia. The CRP is elevated. Condition has worsened. That's not good. So the afternoon update on that second day is there is a blood culture positive, and the initial susceptibility shows no resistance to amoxicillin clavulanic acid, no resistance to cefuroxime, and no gentamicin. We will start a poll to see what you would do. The condition worsens under cefuroxime gentamicin, but you do have an indication from the culture that there is at least no extensive resistant present. I don't see the poll question I intended for this case, so we shall leave that and continue as planned. So this one, case 2, day 3. Now the blood culture shows Salmonella species, testing susceptible to amoxicillin clavulanic acid but resistant to cefuroxime, susceptible to ceftriaxone, and resistance to gentamicin. The condition, unfortunately, the child has deceased. So what happened here? Initially, the test showed no indication of resistance to cefuroxime plus gentamicin. But if you are microbiologically hampered as I am, you know Salmonella species doesn't do well with cefuroxime or gentamicin. So although the coverage was very broad, clinical effect may have been lacking. If you look at European versus American guidance, CLSI versus UCAST, you will find that for Salmonella, CLSI provides you with a quite clear warning, actually for both cefuroxime and aminoglycosides like gentamicin. For Salmonella and Shigella species, aminoglycosides may appear active in vitro, but not effective clinically. And that may have been exactly the case in this infant, having no indication in the initial susceptibility testing of the resistance, but actually no clinical effect was observed. It's not sure that the clinical course would have been better with different antibiotics, but if you look at optimalization and look back at this case, cefuroxime plus aminoglycoside may definitely not have been the optimal choice. Case 3. A young Indian female, 20 years old, living in Curacao with her husband, originally from India itself. No previous history. GP called ambulance for dyspnea due to pneumonia. And upon arrival, the patient is somnolent. There's a systolic blood pressure of 60, a heart rate of 90, respiratory rate of 20, temperature of 40 degrees. On examination in the ER, there's wheezing, there's crackles, the saturation is down on room air, CRP is highly elevated, leukocytosis of over 14, chest x-ray shows infiltrates, and the diagnosis is severe pneumonia community acquired. Blood culture is taken, sputum culture is taken, Legionella and pneumococcus antigen in urine are tested. Patient is started on amoxicillin clavulanic plus ciprofloxacin, a combination very often found in Netherlands with the ciprofloxacin component covering Legionella. Again, we continue. Day 2. Patient is now admitted to intensive care. Patient is intubated. Blood cultures show no growth. Sputum culture shows a lot of leukocytes, but the initial growth is just throat flora and some yeast. Legionella pneumococcus antigens are negative. HIV screening is done negative. Amoxicillin clavulanic was dosed 3 times, is increased to 4 times. That's just a correction to the normal dose. Ciprofloxacin has been given in IV dosing. In the afternoon, the ICU doc calls, there's no improvement with this patient. Shall we switch to vancomycin and meropenem plus caspofungin? In discussion with the ICU doc, he says, well, this is what we do. In this case, the doc was from Colombia. I said, this is what we do in the intensive care. If we have no effect, we escalate to this regimen. Does his proposal match your best guess of pathogens that could be affecting our patient? What community-acquired pathogens for pneumonia should be covered or perhaps additionally tested? Updated the right pane again. Continued. What is the best guess? What should be tested? So is what happens if you follow lines of escalation for community-acquired pneumonia. You may think of bacterial causes like penicillin-resistant pneumococcus, mycoplasma, chlamydiophila, Legionella, more exotic bacteria like Q fever, or even brucellosis if you have regional prevalence of that. You can think of viral pathogens, influenza, of course, but herpes simplex and varicella can cause pneumonia as well. Mycobacterial, you can think of TB. She has a background in India where TB is more prevalent than in Curacao. Or you may think of aspergillosis if your patient is susceptible, and in her case with a no history, no previous history, previously healthy, aspergillosis would not be very likely up front. So in discussion with the intensive care doctor, antibiotics were switched to vancomycin plus clarithromycin, covering the bacterial components, penicillin-resistant pneumococcus and mycoplasmata. TB PCR turns out negative, and PCRs were sent out at that time. There were no local capacity for PCR, influenza, herpes simplex, mycoplasma claviriophila. Day 3, still no clinical improvement, radiological more opacities on the vancomycin clarithromycin. ICU docs, they add meropenem for hospital-acquired pneumonia, which is technically not wrong, being at day 3 and having new infiltrates, but most likely this is still progression of a pathogen initially acquired in the community. Blood cultures were still negative, and the sent-out PCRs are still pending. Well, what could it be? Please look down below. Later out, it turns out that PCR were positive for influenza A, and the patient eventually did not survive. So the bacterial escalation components, they were ineffective, and primarily this is progressive influenza in a very severe fashion, causing death. And it's rare, but it happens. Tamiflu had been ordered, is not standard available, was not standard available at that time in Curacao. Would it have improved patients' course of disease? It may have. Reaching our conclusion, appropriate clinical microbiology in the land of sepsis. It requires adequate testing, and you may find for your hospital a solution in biomarkers, cultures, and I prefer on-demand PCR panels, giving excellent data in our St. Maarten setting. You will need to make an effort to get susceptibility data of your local facility, otherwise you have little grip on how effective your empirical therapy will be and what kind of trends are active in the course of time. You have to make an effort to assume the right focus of infection, and you have to consider the pathogens that can play a role in the infection. Choose appropriately your empirical therapy for maximum effect. We are at the end of my presentation. We did not have all the polls, but I appreciate your participation in the first 2 polls. This time it's time for comments or questions.
Thank you very much, Dr. Steingrover, for your wonderful presentation. As you said, sepsis is a complex syndrome, and we should perform a multidisciplinary approach with prompt diagnosis, prompt antibiotic initiation according to local antibiograms, and prompt de-escalations once results are ready. Thank you so much. We have no questions so far, but we are going to have a discussion at the end of today's webinar. Dr. Steingrover, thank you.
Most welcome.
Our next speaker is Professor Victor Silva. Victor Silva is a head professional with postgraduate studies linked to the academic area in various universities in Chile and abroad, and well as in management and accreditation. Recognized leadership with great ability to form and lead successful work groups both in research, academic, and accreditation areas. Besides directing the School of Medical Technology at the major university in Chile, he is Medical Tech, Mycology Diploma. He has a master's in microbiology and immunology. He is PhD in microbiology from Brazil. He has a postdoc fellow in University of Michigan State. He is a CEO and founder of VCV Consulting in Latin America, and he is also a consultant for the American Society for Microbiology. He works also in the expert committee of the National Institute of Health a chairman of ASOTEM in Chile, and he's also a member of the committee of CONICIT. Professor Silva is going to speak us about invasive fungal infections, epidemiology, and laboratory diagnostics. Please welcome Dr. Silva.
Thank you very much, Dr. Herman Esparza. It's very good to be here. And I want to say thanks to the Caribbean Antimicrobial Stewardship Platform Committee for inviting me, Neila Diaz and Emily from LabKnowledge. And I want to start the presentation right now. Okay. Today we will speak about invasive fungal infection, epidemiology, and laboratory diagnostic. We have only 25 minutes to see the invasive fungal infection, and the follow a slide. The theme will be introduction, epidemiology, and laboratory diagnostic diagram. It's very important to say that our job in laboratory, all the professional at laboratory will be the management of the diagnostics process. We have several phases for this: the pre-analytical phase, analytic phase, and post-analytic phase. And we need to work with the good practice to obtain comparable and quality result for our job. The fungals, mainly yeast, will be with us like microbiota or flora organism. For example, Malassezia, they'll habit in our skin, mainly in adult people, like 90% of the adult people have Malassezia, and Candida like the mucous, like intestinal tract, around 15 to 70%. But Candida don't like the skin. The colonization of Candida in the skin is low, is between 4 to 7%. But the yeast carriage on the hand of health worker is completely different to the community. The health worker, we have a colonization of the Candida in our hand, around 20%, the physician to 80% the nurse. And this is very important because we can transform our hand in to transfer the yeast, the Candida species, to the other people in the hospital, mainly the species Candida parapsilosis. Candida have several species, more than 200. And Candida albicans is the more common agent of the infection around the world. But the most common yeast that colonize our hand is Candida parapsilosis. For this reason, when we have blood culture with high prevalence of Candida parapsilosis, is maybe a consequence that we need to improve our job, our clean hand in the hospital, because maybe our hand is the source of this sepsis. Okay. Okay, the invasive fungal infection, the impact is very high. The yeast is the more prevalent, like 95% of invasive fungal infection in critical care unit, and 2 of the 3 parts of transplant and oncohematological people. After that, called the filament agent, mainly Aspergillus, followed by Fusarium. The yeast, mainly the more common, is candidiasis or candidemia, in this case, cryptococcosis, and other yeasts like trichosporum. By mold, we have the more frequent is aspergillosis, followed by fusarium and mucormycosis. This is the door that the fungus go inside to the patient. By contact, we have the dermatophyte, Malassezia, and Candida. For mucous membrane and catheter, Candida, Trichosporum, Saccharomyces, and Rhodotorula. For traumatic inoculation, Sporotric, Mycetoma agent, Chromoblastomycosis agent. For respiratory, dimorphic agent, Cryptococcosis, Fusarium, Mucormycosis, Aspergillus, Yellow and Feoifo agent. But look at here, Candida. Candida is here by contact, mucous membrane, and catheter. For the medical device, when they are contaminated by Candida, Candida produce biofilm or slime, and it's very hard to treat this, and we need to put out the catheter for this patient. Okay, the early bloodstream infection diagnosis with therapy is very important to the patient. The more common are the bacteria sepsis. The therapy must be administered within 1 hour following recognition. The survival rate decreased 7.6% for each hour of delay in a specific treatment. And the mortality rate is lower, like 20% when the therapy starts at less than 1 hour. But this is high, like 67% when the treatment is around 4 hours after identification of the agent, or could be 80% when the treatment delay 12 hours. Okay. For Candida is similar. Candida is an eukaryotic cell that the growth is more take more days compared with bacteria. And for example, we can have blood culture in media like 30 hours, but there are some blood culture that the yeast could be grow in more days, okay, like 4 days or 5 days. And when the treatment delay in candidemia, we have a high rate of mortality in our patient. The rate mortality of the patient with candidemia is around 40 to 70%. And in the developed country, like Europe or US or Canada, the rate is around 40%. But in undeveloped country like Latin America or Asia or Africa, the rate is around 70%. Okay. Look at here, if the treatment delay around 48 hours, the rate of mortality is around 80%. Okay. For this reason, we need to introduce technology and to our laboratory to identify early the candidates or other yeast, try to save the patient. Okay. This is only to show the epidemiology rate from Latin America. This is an last paper from 2090 that was participate several countries from Latin America, and the overall was the incidence per 1,000 admission, the overall was 1.18. And this is very high compared with the US, that the rate is 0.28 to 0.96. And for Europe is 0.20 to 0.38. But there are some countries that is very high. For example, in Colombia is 0.96. Okay, Argentina 2, Brazil 2 is very high, and Venezuela is very high. Okay, and we don't have data about the Caribbean island from the Candidemia incidence or prevalence. And where is the main species in this country? The first or the more common species is Candida albicans, but in the second species is Candida parapsilosis. It's very high frequency. For this reason, I told you that when we have a high frequency of Candida parapsilosis, maybe it is associated to nosocomial infection with the yeast come from the hand of the people, from the health work in the hospital. This is one of my study from around 366 patients with invasive fungal infection by several yeasts. More common are Candida species, followed by Cryptococcus, Saccharomyces, and Rhodotorula. The species, this is newborn, children, and adult patient, male and female. And look at here, Candida glabrata is a very special yeast because this yeast develop fluconazole resistant easily. And this is isolated in Chile mainly from adult people and mainly from women. Why? Because there are several years ago, the fluconazole is used in monotherapy from vulvovaginal candidiasis. Maybe this therapy, Candida glabrata, was a selective pressure, and right now Candida glabrata colonize the vagina from many women, and when they go to the hospital, the Candida glabrata transferred to the blood culture or to systemic and cause the sepsis by Candida. We do the molecular study to confirm this hypothesis several years ago. Candida krusei is natural resistant to fluconazole, and we can isolate it in children, in newborn, in adult. There are no difference. And Candida parapsilosis, we can isolate in all kind of people, newborn, children, and adult people, men and women, okay? But Cryptococcus neoformans in Chile is isolated mainly in adult people and mainly in men. Why? Because it's associated to HIV patient, this infection, okay? Okay, this is the diagnostic diagram in medical microbiology or medical mycology. We need to start. Remember, we have the pre-analytical, analytical, and post-analytical phase. And the clinical diagnosis is very important because the physician say that maybe this infection is caused by fungus or bacteria or virus. And in the laboratory, we select different route to go to try to get it a virus or bacteria or fungus. For this reason, it's very, very important that the physicians say, maybe this is or I suspect that the sepsis is for bacteria, but maybe there are fungus too, or is an alternative. For this reason, it's very important the good communication between the laboratory professional with the physician. The sample collection is very important. Our results in the laboratory is very related to the quality of the sample collection. In the microbiology lab, we need to do the direct microscopic examination to all the samples that will be suspect of fungal infection. Could be a fresh, like a vaginal sample, for example, or urine sample, or a smear with Gram or Giemsa or another ink. And we need to share or send the preliminary report to the physician. This is very important because the fungus, some genera or some species of fungus grow slowly. For this reason, the preliminary report for the direct microscopic examination from the clinical sample is very, very important to send the preliminary report to the physician, because this is a good information to start and treatment or change the treatment according to our result. In parallel, we need to do the culture to isolation the agent, and after that for identification. We can use the conventional protocol or automatic system or molecular biology to the identification. It depends on the accuracy of our laboratory, and it depends the quality of our hospital too. We can use immunodiagnosis to detect antigen or detect antibodies too. And don't forget the susceptibility to all the yeast isolated from blood culture, okay? And when we finish the ID with the susceptibility, we need to send the final report, okay? But I recommend to the laboratory send the information to the physician. For example, if the culture we isolated a yeast, we can say to the physician, okay, we isolated a yeast, and maybe this is a Candida albicans or Candida no albicans. This is very, very important, because if the species is Candida albicans, the physician have more disponibility of several antifungal to treat the patient. But if you say to the physician, oh, I think this is Candida no albicans, the quantity of antifungal to use in the patient is less, okay? Okay, the clinical sample is the major step in diagnosis of medical mycology, and remember the sensitivity of the is directly related to this process. The procedure vary according to the type and site of infection. For example, in skin or mucous membrane, usually by scraping the lesion. Urine is usually puncture the catheter, and blood from peripheral line and or catheter before fever spike, okay? The sample must be accompanied by a microbiology study request with the medical presumptive diagnosis and patient morbidity data, underlying disease and predisposing factor, and use of treatment, etc., for our laboratory diagnosis criteria, okay? This is very important. This is a system to vacuum that the hospital send the sample to a central. At the central, send the sample to the different laboratory, including microbiology lab. Okay, this is very important because it's quickly and safe and automated the process. For the sepsis, the main step is the blood culture. We can use this system, okay, the blood culture for children, for adult people, for newborn, could be a little bit different, the quantity that you put the blood in the vial, in the bottle. And we use this machine that are very, very useful to use, and they say to us if they detect, when they detect some grow inside, and we need to pass to next step, that is do the gram stain. Okay, this is another picture. This is several blood culture. Okay, and the direct microscopic examination is very simple, useful, rapid, and inexpensive to mycology diagnosis, but we need experience of the professional. Okay. The relative performance is according to professional experience. This is a problem, and we need to capacitate the people to do the direct microscopic examination to identify the fungal cells in the clinical sample. Okay, the direct microscopic examination, the laboratory can do manual or in machine, but the result you need to put in the microscope and look at very well the lamp on the slide, and it's fundamental in the diagnostics process of mycosis. It's fast and applicable in every level of microbiology lab. The fungal cell detection, structure identification, and interpretation require experienced professional and allow early treatment initiation. For this reason, it's very, very important to send the result to the physician quickly. And here we have in this slide a direct microscopic examination from blood culture with gram. And look at here, we detect fungal structure like a yeast. This is a pseudohyphae with yeast. And this is another structure that is a pseudohyphae too, but it looks like maybe similar to hyphae. And how can I say that this structure is an pseudohyphae and not a hyphae? Look at here, the arrow shows that the branch is in this point that look like a sept, and we have a branch here. All the pseudohyphae from Candida are the same. Remember, the branch for this point look like a sept is a pseudohyphae. Okay. This is another yeast direct microscopic examination from Cryptococcus. This is a bronchoalveolar watch. This is cerebrospinal fluid, and this is blood culture. And look at Cryptococcus is a very round cell, very homogeneous, very round, with capsule around. Okay, could be a small capsule like this, or big capsule like this, or this like Mickey Mouse. Okay, or this is in gram stain, a very round yeast. Okay, when you look at a very round yeast, you need to suspect in Cryptococcus. Cryptococcus is urease positive and Candida is urease negative. Okay, but after the gram, we say, okay, this could be a yeast, and we need to identify quickly the species of these yeast. We can use the multiple PCR film array. That's in a system, a closed system. The result is in 1 hour. It's easy, accurate, and high performance. Okay, this is a multiplex PCR inside of this cassette. Okay, this gallery. And the film array from blood culture identification panel can identify 24 different microorganisms: gram-positive bacteria, gram-negative bacteria, and 5 yeast species: Candida albicans, glabrata, cruzae, parapsilosis, and tropicalis. There are another species that cause infection and sepsis, but these 5 species, okay, is the more frequent. Maybe we can detect more than 90 or 95% of our candidemia in our hospital, identifying these 5 species, okay? And we can detect some resistant genes too from bacteria. This is very easy to do, and it's very quickly. Only in 1 hour we have the identification, the ID. Okay, this is only to show that we can do an individual PCR in this machine for a film array, or multiple at the same time with the other machine. Then we have several. This one is PCR. This is very important because I want to show you that this is, for example, a laboratory that works only Monday to Friday from 8 p.m. to 18 p.m. To 6 p.m. The first is the time to isolate it and identify the bacteria. For example, gram-positive is around 100 hours in media, and from gram-negative is around 80 hours to send the result to the physician. But this is an laboratory 24 hours, 7 days. And when they use work 24 hours, 7 days a week, the quantity of hours to send the result is lower. Here, the gram-positive is around 17, and from gram-negative is around 50. And the yeast is around 100. But when we include, for example, in this same laboratory, 24 hours, 7 days a week, film array or molecular diagnostic, the time for send the result to the physician is lower. Look at here is around 25 hours for gram-positive and gram-negative, and less than around 50 hours from yeast. Okay, this is very useful because the rate of survival for the patient is high when we send the result quickly to the patient, to the physician. This is the culture for several yeasts: Cryptococcus, Candida, Malassezia, and Trichosporum. And this is only to show when the traditional ID is a physiological and biochemical test. And when you do that, we can use chromogenic agar because it's very useful to see that the culture is, there are only one species or maybe two, like this case. This was in one patient, that blood culture, and we identified 2 different colors. One of them is Candida parapsilosis, identified by Vitex, and the other is Candida albicans, identified by Vitex. And this is very important because maybe the pattern of susceptibility could be different, okay? And it's very useful work with chromogenic agar. Okay, you can use from the colony, do the ID by mass identification, okay? Allow identification of fungal species from culture is fast and very reliable result and wide update database, okay? With the spectral use this technology is very useful. Or if you don't have molecular tool, you can use automatic biochemical tests or enzymatic tests like Vitex, okay? That the result is very is quickly too. It's more quickly than when you use the traditional ID from yeast, okay? But when you work with Vitex, the inocula is a critical step, and for example, to do the ID for you can use 2 McFarland range, but for antifungal susceptibility you need to do 0.5 McFarland range, okay? This is very important to do that. And this is only to finish to show the disk susceptibility test and the gradient step to susceptibility test for yeast. It's very useful to do that, and it's very confiable, and it's a good information to send to the physician if the yeast is susceptible or resistant to some antifungal. And thank you very much for your attention. Thank you very much for your patience too.
Thank you very much, Dr. Silva, for your excellent presentation. I think fungal diagnosis is really a challenge for many of us. So understanding the step-by-step of this process definitely will be so useful for clinical labs around the Caribbean and also in South America. Thank you again. So for all of our attendants today, I would like to remind you that the organization of LabKnowledge will send you later today a link to complete the evaluation for this webinar. And this evaluation is mandatory to get the certificate for attendance. So we have a few minutes for a couple of questions. We have right now some comments, and I would like to ask you, Professor Silva, and also to Radjin, about what do you consider right now the biggest challenges that we have been facing with COVID-19 and all those multi-drug resistant pathogens, not only bacteria, but also yeast. What do you think about that?
Was that a question for me or for Dr. Silva?
For both.
For you, Radjin, first.
I think the good thing about COVID is that it gives us a review of our process for pneumonia. It is a very big case to review pneumonia processing. We have updated our diagnostic processes. I think in the challenging part, it is difficult to see anything but COVID and have the physicians also focus on the bacterial and other pathogens at this time.
Thank you, Dr. Steingrover. Professor Silva, any comment about what do you consider that may impact in fungal infections in this COVID-19 pandemic?
Thank you, Dr. Esparza, for your question. It's very important because we look around the world, there are several information about the patient that are in critical ill patient unit that will develop aspergillosis, for example, okay? Pulmonary aspergillosis or invasive aspergillosis too. I don't know right now what is the real association or if it was by a contamination of some medical device or not. But we are looking at high rate right now of aspergillosis, invasive aspergillosis from this kind of patient. And this is very bad for the patient because the aspergillus treatment is not easy, and the critical condition of this patient is very bad, and more of them go to the no good response to the treatment, pass away.
Thank you very much. So my second question for you both will be related to access to some bundles to control sepsis. So Dr. Steingrover, do you consider that we have been moving forward better diagnosis in the Caribbean for patients with sepsis? And what do you consider probably are the biggest barriers or issues or probably limitations that we have in the Caribbean to deal with sepsis management? Thank you.
Well, that's an excellent question, and I think you can answer that in many ways. Actually, we have challenges in getting our figures. That we have to know how big is the problem and are our interventions effective. I don't think we have good sepsis data in our islands. It's very difficult to have those. Also because of the change in definition, that the definition of sepsis has changed over the years. So it's difficult to establish that baseline, but I think at this time it would be a very good idea to do that. If you look at the process of care, the speed of action is tremendously important. And I think if you look at how we care for our patients in the Caribbean, to have that speed adequately at that first hour, that golden hour, I think we will find many cases with suboptimal care, not completing care in that first hour. And I think if there is a prime importance, the speed of care is the most urgent one. And I think secondary, we have to look at resistance in bacteria, gram-negative, gram-positive, and make an optimal match with our empirical therapies.
Thank you very much. I really appreciate your comments, and definitely we agree that we have been facing probably the same issues and limitations and threats also here in Latin America. So I would like to remind you for all the attendants that you can type your questions in our chat room so I can read them for our speakers. And I would like to get back to Professor Silva. Professor, regarding Candida auris, so we used to be like scared about this pathogen because it seems to be, a very important threat for local epidemiologists in the way that it can spread rapidly. However, it hasn't happened in many countries as we expected. Probably we still have issues mostly with Candida albicans and Candida tropicalis. But unfortunately, some clinicians and also people from the microlab do not think about those yeasts when starting the diagnosis approach. What do you think about that?
Okay, Candida auris is a very special yeast. They come from Asia too, okay? And this yeast is very difficult to the treatment because this species not work well to the traditional treatment for the sepsis. And the other thing is Candida auris colonize the surface in the hospital, and it's very hard to put out this yeast. In some case, they found the yeast in the surface in the UCI, for example, several days after the patient died. For this reason, I think that today, with this new form to work with the pandemic COVID-19, maybe is more controlled this Candida auris infection. But fortunately, today the automated system include the software to identify Candida auris better than the past, because 1 year ago, for example, the ID for Candida auris was very difficult in several laboratories around the world. But today, for example, some automated equipment have the software, software, to can identify the group of Candida auris and the other yeasts that are very closely to Candida auris, okay? And for this reason, it's very important to use this technology. And if you use in your laboratory only the traditional method to work in medical mycology, could be very, very hard to identify these yeasts, for example.
Thank you very much. And one probably, Professor Silva, difference between some automated systems to perform antimicrobial susceptibility is that most of them do not perform antifungal susceptibility testing. So I would like to get back also to Radjin and ask you, Radjin, if you consider that our islands in the Caribbean, are they performing susceptibility for yeast, and if something should be improved regarding susceptibility for all those fungal pathogens?
Yes, I've worked on several islands, Curaçao, Bonaire, St. Maarten. We are very interested in the susceptibility of the yeast, and we are performing it on the Vitec platform with the yeast. I think it's 07 card. I recognize the struggle we had in the beginning, where the cards were not able to identify Candida auris, because we were on high alert at that time when it broke out. We felt susceptible for outbreaks, and we were scrutinizing all albicons with some resistance. But I think for the clinical isolates, we do have good performance of the yeast cards on the Vitec, and we do have susceptibility testing available basically on every island. Yes.
Thank you very much. Any comment, Professor Silva, regarding susceptibility for antifungals? I mean, in South America, what do you consider that should be improved?
I believe that we can improve, obviously. But for example, there are many countries that don't have money to implement the new technology. For this laboratory, they can do properly the antifungal susceptibility tests, implementing, for example, DISC test for like Kirby-Bauer methodology, for example. It's very easy to do. And the susceptibility test, when the yeast is a big allo and is identified or recognized like susceptible, this result is true. But when the allo is small and the interpretation is resistant or is susceptible dose dependent, do you need to prove by a quantitative method like automated or like e-test, for example? Okay. For this reason, in Latin America, in the country, there are Candida work very well in vitro to the more frequent antifungal. For this reason, for example, if you isolated 100 yeast and you need to do the ID from the blood culture, you can use this system, the qualitative susceptibility test by DISC, like a screening, And maybe you can say 80 or 90% of the strain was susceptible to all antifungal. Do you need to repeat by a quantitative method? And do you need only to invest money to incorporate a gradient like a test for the other 10% or 20% of the yeast? This is a good combination that I recommend to some small laboratory or laboratory that don't have money to implement the automatic work inside the laboratory. It's okay.
Thank you very much. So it has been wonderful. Thank you for your presentations, and thank you all the attendants for staying with us. Don't forget to fill the evaluation to get the certificate of attendance. We will get together again tomorrow for our live webinar with a couple of good speakers, also telling us about important topics in sepsis at the same hour, what is 10 a.m. Curacao time. Thank you also to LabKnowledge and our sponsors to make this real, and let us share experience in how to handle sepsis diagnosis and treatment. I hope you guys have a nice day, and please keep safe.
Thank you. Thank you very much.
Thanks. Well said.
Bye-bye. See you next year, maybe. Bye-bye. Bye, Radjin.
An explosion of art, architecture, and restaurants has spurred redevelopment, transforming Curacao into one of the hippest destinations in the Caribbean. But the island still radiates its European charm, natural beauty, and wonderful mix of Dutch, Spanish, Caribbean, and African cultures. Visitors must go and feel it for themselves. Located on the outer fringes of the hurricane belt, Curacao is easy to reach by nonstop flights from 6 North American gateways and by same-day service from 40 cities in the USA and Canada. Still a member of the Kingdom of the Netherlands, daily nonstop flights arrive from Amsterdam, and many flights arrive from South American and Caribbean locations. English is spoken widely, along with Dutch, Spanish, and Papiamentu, the local language. Curaçao's dry, sunny climate and an average temperature of 87 degrees Fahrenheit make it a mecca for every variety of outdoor activities. Visitors won't have to change money. While the official currency is the Netherlands Antillean Guilder, or NAF, US dollars are widely accepted. And the water is safe to drink, straight from a modern desalination plant. Want to know more? Watch our other videos to learn all the things you need to know for planning personalized dream vacations. You'll see where to stay, lounge, dine, and party. You'll get tips on the hottest areas like the Peter Mai district, the best beaches, where to access shore and ocean dives, and all kinds of land and water-based activities, some that are unique to Curacao. So, welcome to Curacao and its hot new vibe. Visitors must go and feel it for themselves.